the World Health Organization, for all those countries which have less than 2 specialized health workers who can do these procedures in the countries per 100,000 people who need the service, they will not be able to meet the target of having 80% of the health seekers being covered by these emergency obstetric care services. So what did we do at the center? The center, as part of the university, works to generate evidence. What is happening in other countries? So we conducted a 7-country survey on what are the experienced countries doing. And actually what we find is that there are countries that have adopted this have been able to meet up to more than half of their required coverage of emergency obstetric care services because of shifting tasks to less specialized health workers. Shifting tasks is a procedure which is done by a specialized person like a doctor or a surgeon, is given to a less specialized person like a midwife. And actually what he has been saying, a community health worker even giving information about health, is actually shifting that task from the health worker to a village health team member. So when we conducted this study, we found that actually in this region, countries like, starting from Ethiopia, Tanzania, Malawi, Zambia, Mozambique, have actually shifted such tasks to lower specialized health workers. But these people are given competence-based training and given the emergency obstetric skills, and they provide these services just as well. Studies comparing quality of the services given, especially even the cesarean section, which is one of the most important life-saving procedures, there's no difference between the complications that arise having from a specialized health worker like a surgeon doing the Caesar and a less specialized person like a midwife having done that Caesar, but given the adequate training. So what are we bringing to countries like Uganda? Uganda has one of the best health education systems. We produce some of the best doctors, but these doctors, as soon as they finish, there's internal attrition, they go to NGOs, they go to teaching activities, then they go to other countries. So the people we remain with are the clinical officers, the midwives, and those you find money from health center force, which the government is relying on to provide these services. So we are saying that should this intervention, which is actually more cost effective, based on the fact that producing a midwife or a clinical officer takes 3-4 years maximum. Producing a doctor takes 6 years. And a specialized doctor, you have to add other 3 years for this person to master. We agree and welcome the idea that, of course, the specialized doctor has a lot of knowledge and experience in several things. But there are those services that are needed for emergency care, treatment of abortion, delivering a mother by cesarean section. And they are needed in Amudat, they are needed deep down in Kanungo, they are needed in Nebi, they are needed at the lowest part of this country. So we are saying that let's give health workers, let's specialized health workers, competence-based training for those special interventions that are required. And let the policy be behind this. And one of the most important success factors we found in other countries, including Tanzania, Mozambique, is political support. Once it's given the support, it's given the funding, the College of Health Sciences is already here. We have several medical schools training these people. Bring them back, give them the competence-based training, and I'm sure this will be one of the best interventions that we shall have provided to our mothers in this country. So, among other things, we think shifting these specialized tasks to less specialized health workers will contribute to the availability of these services to our mothers in this country.